I'm going to talk about not only our research, but research really informing the neurobiology of alcohol dependence and its treatment, and really linking that to what's happening in the clinic, because it's been quite an exciting time over the last few decades. Just a note on disclosures: whilst the majority of my research is funded through the MRC and NIHR, I have had some industry funding from companies there and act as consultants for a variety of other ones as well. I just want to spend the first slide really talking about what we're meaning by alcohol dependence or problematic alcohol use, or because I think it is important to understand there's a gradation of problematic alcohol use, and obviously it may be that you're a low risk drinker, but below 14 units a week. But then as your drinking may escalate and increase in volume, but also frequency, the maybe impact on your health, maybe sort of hazardous use, a warning that there are going to be some problems. But once you have an impact on your physical health, either your liver or your brain or your heart, you have crossed the threshold into harmful use. And then obviously at the top of the pyramid is the most severe, which is alcohol dependence. Until very recently, the diagnostic criteria, both in the United States, the DSM, and the global, the WHO, the ICD, which we use in this country, were exactly the same. But there's been a change, which is really important to understand. And the change is at the top. So it's about alcohol dependence. So for me, the critical thing is about lack of control. So if somebody has lost control of their consumption of alcohol, like in fact any other drug, they are very likely now to have crossed that threshold into being alcohol dependent. We used the same terminology across all diagnostic criteria, but that changed a few years ago. So we now have in the States a continuum where depending on how many criteria you meet, you may meet the threshold for an alcohol use disorder. And then depending on how many criteria, if you meet 6 or more, then that is severe alcohol use disorder, which is akin to alcohol dependence. The reason why I'm labeling this is in the media or when trials get reported now, they often don't give you the severity. So it's unclear whether the intervention or the thing they're talking about is aimed at alcohol dependence. And I'm really going to focus mostly on this talk in terms of interventions to that most severe end, the alcohol dependence, and people who've lost control of their consumption. Underpinning everything is psychosocial interventions. And this is a recent guidelines that have just been published, which I'll come back to. This is an overarching, quite busy slide. But the key thing is problematic alcohol use, first of all, has to be recognised and then appropriately assessed, and then work out what is the correct pathway for somebody to go through. The very basics, somebody who's got maybe abnormal liver function tests or high blood pressure, that may be due to their alcohol consumption. Feeding that back to them is an evidence-based brief intervention. So at one end, you don't necessarily need very specialist skills to do that, but understanding that relationship is really important. Through to obviously people who are really struggling with their control of alcohol consumption may require much more specialist intervention for somebody like myself. And obviously, once somebody is drinking regularly, it is highly likely they're going to have an impact on their physical and mental health, which then also need managing as part of the complete picture. So where does the first bit of neurobiology really come in? And I'm going to focus a little bit on detoxification or experiencing alcohol withdrawal. So anybody who's now lost control of their consumption is very likely to experience alcohol withdrawal. And this can be life-threatening, such as having a seizure or fit, or something called delirium tremens, where you may see the classic is small furry animals running up and down the wall. But these are life-threatening, and therefore it is critical that whenever people are presenting for treatment, or people be aware of this, that repeated episodes require lead to worse symptoms and greater risk of complications. So what is the biology that's underlying this? So what alcohol does, it gets into the brain and it actually specifically affects quite a lot of neurotransmitters. And one of these, or two of these, sorry, is the excitatory system, the glutamate, and the inhibitory system, the GABA. And if you think about these as almost the yin and yang of the brain, they're keeping everything sort of ticking over, and they've got to be in sort of, we don't want one to be out of kilter with the other. What happens when you drink alcohol is actually what you do is you boost the inhibitory system. And that gives you the anxiolytic effect, so it reduces anxiety, Dutch courage, or is the sedative effect. Now, those two reasons are very commonly why people start to drink alcohol. And it's very effective at boosting that inhibitory system, and it does it quite specifically at the receptor. On the other side, being the clever chemical that it is, it blocks your excitatory system, particularly a receptor called the NMDA receptor, but it blocks the glutamate system. Now, the glutamate system is essentially in laying down memories. And so by blocking that system, that's what we believe underpins alcoholic blackouts. So those people who go out drinking and then cannot remember that episode of drinking. So this is what alcohol is doing to the brain acutely. And so the brain starts to adapt because it wants to get back to that homeostatic. It wants the GABA and glutamate back in alignment. And so what happens is, to counter that blocking, it upregulates, it increases the number of glutamate receptors. And because you've been boosting the inhibitory system, that system becomes less sensitive to alcohol, which is why I've made the receptor smaller there. So again, you've got them in alignment with each other. But alcohol is really critical to keeping that steady state. The problem comes when you have no alcohol in the system. So suddenly you have a glutamate system that isn't being antagonized, it upregulates. And this drives a lot of the toxicity and the problems related with alcohol withdrawal. Increasing calcium into the cell, hyperexcitability leads to seizures. It also kills off the cells and leads to cell death. And we know that alcoholism is associated with lots of atrophy. On the other hand, you've got the reduced function in an inhibitory system. And so you actually have a very toxic mix. And this is why treating alcohol withdrawal or even anticipating it and giving medication to cover it is absolutely critical, because you want to prevent these complications. So what do? We give a drug, a benzodiazepine, such as Valium or Librium, chlordiazepam epoxide, or diazepam, to boost the GABA function. And it does this really well. Gold-plated, gold star evidence, really effective at reducing risk of complications. We also have to think of other things to reduce brain damage, such as making sure there's sufficient vitamins, because lots of people with alcohol problems are deficient in thiamine, and you have to give it via injection or IV because we don't absorb enough. So that's what we do to try and protect the brain. But if you were going from first principles, you would look at this neurobiology and you think, well, maybe we should be targeting the glutamate system. And actually, there is a wealth of preclinical evidence and some preliminary clinical evidence that a camprosate can do this. I'm going to mention camprosate in a minute, but it's a drug that we use to help people stay abstinent. But we know what its pharmacology is. We know that it modulates the NMDA receptor and calms glutamate down. So this is a really effective drug. And in my clinical practice, we introduced it complementing the benzodiazepine. And we did see results where patients reported better sleep, this alcohol withdrawal settled quicker, and the nurses also reported this as well. So that's the way, through biology, that's really helping treat alcohol withdrawal. If we now move into relapse prevention, and we focus on pharmacotherapy and medication to treat people who are now clean and abstinent, but how to keep them abstinent, prevent them from relapsing. And just as a word, it's always as an adjunct to psychological treatment. Now, George Koob many years ago devised this three-stage model about how to think of addiction, not only for alcohol, but other substances as well. And we actually have mapped pretty accurately all the different parts of the brain are involved. So when we're developing treatment for alcoholism, we're not just pulling them out of thin air. We actually know which parts of the brain we're targeting. So if you first of all look at the binge intoxication, that's the first part. Most people, as I've said, sort of drink and will get pleasure from it. And that we know is very much to do with this blue part, this striatum element here. And we know that's really critical. As I've already described, some people like to drink to relieve anxiety, or actually their withdrawal, which perpetuates drinking. That's known as negative reinforcement. This is a different part of the brain, and the amygdala is critical here. And then we have the front part of the brain, the frontal cortex here, which is very much associated with the craving and the control of one's desires to drink, and the projections down from the green part of the brain into the blue part of the brain, the frontostriatal, are very critical in this. Now, what we have is a really super dense map of all the neurochemistry involved. And I realize the print's too small for you to read, but I want to give you the idea that we actually know of an awful lot of targets, and the majority of these are under active investigation, including some through our team. But I'm going to focus on a few of them, particularly the dopamine and opioid systems to do with the prefrontal cortex and the striatum. And I'm also going to mention about the stress system here in terms of withdrawal and anxiety. So we're using this biology to inform development. But I just want to mention before that the acamprosate. So this is the drug I've already mentioned. This is the first line treatment for anybody with alcohol dependence to help them stay abstinent or sober. As I've already mentioned, we know that what its pharmacology is. It's attenuating this imbalance between GABA and glutamate. What all the trials have shown is this drug is really good at increasing abstinence. So I'm not going to go into much detail about how you use it, etc. We don't have time. But if you're going to use it, then start it during detox. Give that potential neuroprotection to the brain during detox. There are very few contraindications, so it's actually a quite safe drug to give in those with quite severe medical or physical or mental health impairments. And generally, we suggest giving it for up to 6 months. But if it's not working, because we know that the neurobiology of alcoholism is different for different people, I would stop it after 4 to 6 weeks. If we move on to naltrexone, which is another first-line drug. Now, this is predicated on knowing that if you antagonize or block the opiate receptor in the brain, which modulates dopamine, which is to do with reward in the brain, in that blue part of the brain, it was known from animal studies that they would stop drinking alcohol. In man, it does reduce the pleasurable effects of alcohol, it reduces craving, and it attenuates how the brain responds to salient cues. And I'm just going to show a couple of meta-analyses or reviews of that. So on the left here, we have a slide of quite a number of studies where people went into the scanner and they looked at pictures of alcohol. And these red blobs here is where there was extra activity in the brain of somebody with alcohol dependence compared to control. And as you can see, that's the striatum in the middle here, and this is part of the prefrontal cortex here. So what alcohol cues are doing is they're overactivating this reward system in the brain, which then drives the experience of craving and people alcohol seeking. If one treats somebody with naltrexone, one of these opiate blockers, or actually cue exposure therapy, so psychological therapy, these blue blobs mean this is where the area of the activity in the brain is being reduced. So what we know from a drug like naltrexone is it can calm the brain down and make it not react as much to salient cues. And therefore that probably underpins why it reduces craving. So this kind of imaging is now being used as a biomarker. What that means is we know that if a drug changes how a brain responds to cues, it is very likely to have some efficacy in the clinic. So it's a way of doing a first screen in drug development. And we're involved quite actively in that in Imperial. Now, when you look at the effect of this drug, it's really interesting. It's not like acamprosate, but what it does is it reduces the likelihood of a lapse becoming a full-blown relapse. So if somebody is struggling to stay abstinent and has the occasional lapse, what this drug seems to do is prevent that going into full-blown relapse. So it has a slightly different use to acamprosate. And again, I can't go through all the details, but the main reason in my career of prescribing this that now means I can't prescribe it is the large number of people now taking opioid analgesia. So you can't give an antagonist when somebody is relying on a drug like codeine to treat their pain because you're going to block that effect. So, that's one of the changes. And the other thing is it's not good, the types of patients that Mark would see with very severe or acute hepatic impairment, you can't give it in that. So there are some contraindications. The other drug, just very briefly, is also licensed and recommended in this country, but it's second line, actually works through the liver primarily by blocking an enzyme called aldehyde dehydrogenase, and it leads to a buildup of a metabolite called acetaldehyde. And that leads to a whole raft of aversive effects, which basically essentially stop people from drinking, but they can be life-threatening because of the effect on the heart. You have to warn people, alcohol's not only in drink, it's in food, perfume, aftershaves, and any of that alcohol will lead to that effect. Interestingly, the same family of enzymes exists in the brain, and it evolved in the metabolism, noradrenaline and dopamine. So it can change those levels in the brain. So it may affect the reward pathway and maybe the stress pathway, but we don't know that yet. The main effect is on the liver. And again, this is about abstinence. It's less a favored drug because of all the risks of interactions and side effects. So go and have a look at that. In terms of the nalmefene, this is another opiate antagonist. Has a slightly different pharmacology to naltrexone. And so I've talked about this blue positive reinforcement being involved in the mu and the nice and the pleasure. But there is another side to opioids, and this is the kappa side, which is involved with negative reinforcement and dysphoria and not feeling very good if you stimulate the receptor. And nalmefene is better at antagonizing that than naltrexone. So nalmefene has been licensed. It similarly acts in the brain, and we have also shown that it can reduce the reward system, it reduces the response to cues, but you give it whilst people are still drinking. So the idea is you extinguish the pleasure of drinking and people will stop. You have to give it to therefore somebody who's less, you couldn't give it to somebody who's at risk of having a withdrawal problem. So you do need to focus on those that are less dependent. And therefore, can you give naltrexone instead? Yes, you could. And there's also, in fact, there was an article in the media in the last few weeks using this drug to get people to reduce their consumption who aren't necessarily dependent, from what I can read in the media. So there is a bit of debate going on is whether you could use this drug to help people who maybe have not developed lack of control, but are very close to doing that. Now, the last drug that is widely used in this UK, in fact, was led by a trial from hepatology in patients with alcoholic cirrhosis, so quite severe liver impairment. This is baclofen, which was repurposed from it's used to treat muscle spasticity. But we know its pharmacology, we know it modulates dopamine in the reward system, and we know it changes brain response to salient cues. So we know why it works. So we have biological validity. It's about abstinence. We do not recommend you give it to people who are still actively drinking, but that is different in different parts of the country and world, rather, and I'm happy to answer more questions. It isn't necessarily a straightforward drug to use, but there is debate about the dose. In France, they went up to 400 milligrams a day. We would recommend no more than 60 milligrams a day, i.e. 20 milligrams 3 times a day. And there are the reason the liver specialists were interested in, because it can be given in people with liver impairment. So it was giving an opportunity to a lot of patients who other drugs weren't suitable for that it could try. But there are some cautions and contraindications. And for those of you who would like to look at it, do go and look at those statements. We do know that people with alcoholism from our research are less sensitive to this drug, so you may need slightly higher doses, but you do need to proceed with caution. How could I have a talk and not mention GLP-1 agonists? So our group, led by Tony Goldstone, has been looking at GLP-1 agonists, in fact, a variety of appetitive hormones. There is a good evidence, again, about why they might be really good in treatment of alcoholism or maybe obesity as well, and also smoking, and well as other drugs such as opiate dependence. The trial recently came out that was like, actually, when you look at it, it did have some positive effects on drinking, as I've put here from Hendershot. But I just want to make it very clear, this is coming back to what I said about the diagnosis. It was not in those that were treatment-seeking populations, so they didn't have severe dependence. These were much more like a more problematic or harmful use. So it is unproven whether it's going to work in alcohol dependence, but it may have immense value in maybe the larger population who have problems with their consumption. So it's a watch this space. The other watch this space is the use of pharmacologically assisted psychotherapy. Now, this is again quite a lot in the media. I'm involved in a ketamine assisted psychotherapy study for alcoholism. We did a proof of concept. We showed that ketamine, in addition to psychotherapy or education, improved outcomes. The idea is that you come in, you have your ketamine infusion, you then come back the following day for psychotherapy, psychological thing. Same principle for psychedelics such as psilocybin, DMT. You're probably aware of the news this week about DMT and studying depression. The idea is that what you're doing by giving that pharmacological nudge to the brain is that you're enhancing the plasticity of the brain, breaking maybe connections that aren't healthy, to allow new connections to be made, to rewire what they put here, maladaptive memories. It also may be antidepressant, but this is a new exciting avenue, and you know, Imperial's at the center of this, obviously world leading psychedelic center as well. So I just want to make the point really is there's a wealth of pharmacology. There's a wealth of evidence behind. We're not just randomly picking targets. We know, and a lot of them are really highly characterized in animal models, come into man. Imaging is key and central in this, and that's where our group plays a key role. But for the clinician, I think it should be an active decision not to prescribe a medication to help somebody remain abstinent. And I've put down the drugs here, and I'm happy to answer any more questions about that. But the less than 1 in 20 get into treatment, and less than 5% of those get offered medication. So we could be doing an awful lot more to improve the access to this. And the very last thing I just wanted to mention is these clinical guidelines. We've been waiting for them for some time. They started being written in 2019. I've been involved in this. I know several hepatologists as well, and other. It's a really good resource. I put the QR code on there. As you can see, there's a variety of different care settings, and you know, it's a wealth of information. And I do urge you, if you are a clinician or just interested in hearing, reading more about what should be available, to please go and have a look at that site. With that, thank you very much.